Good evening, guys. Welcome again. And we are going to talk about medical problems in obstetrics, and those medical problems which are very important are hypertension, pregnancy, and GDM. And please remember, both of these topics regularly come as your exam cases also in your final year. So, in this quick fire revision, we are going to discuss about those intricate bits which come in your exams as theory also, and also come as your viva questions, right? So, let's see hypertension first and then diabetes. But before I go into detail, I want to give you a broad understanding of these two topics. Look, even if you're joining late in this class, I want you to understand this upfront. Hypertension pregnancy and diabetes in pregnancy. Both I'm going to give you a common information which is extremely important for the understanding. Hypertension can be chronic. Let's see, there's a girl who is only 15 years. At 15 years of age, she has high blood pressure. Already she's a case of hypertension. She gets pregnant, let's say at 30 years of life. At 30 years, when she's pregnant and she comes to me at 7 weeks of pregnancy, she's already a known case of hypertension. So what kind of hypertension that is? Chronic hypertension, which is presenting in pregnancy. Or they can be women, let's say a 29-year-old woman who's got married and she's now pregnant. She's never had hypertension and she's now coming to me around 24-25 weeks. Now her blood pressure is high. So if the blood pressure increases after 20 weeks, then we say it is gestational hypertension. So hypertension pregnancy can be two types. The chronic hypertension, she's already a case of hypertension, now got pregnant. Or it can be gestational hypertension, that the blood pressure is high for the first time during the pregnancy. Now, when that happens, when the gestational hypertension happens, this is happening after 20 weeks. So this will have a somewhat better prognosis as compared to gestation, as compared to hypertension, which is present from many years before she got pregnant. So chronic hypertension will behave worse. So let's say you could be having chronic hypertension because of essential hypertension, renal artery stenosis, or pheochromocytoma, whatever reason. And gestational hypertension is blood pressure more than 140/90 after 20 weeks. And obviously, chronic hypertension will have worse prognosis in pregnancy. Similarly, we have the same understanding for diabetes in pregnancy. A young girl, let's say a 10-year-old child, she's a case of insulin-dependent diabetes mellitus. She's on insulin all her life. She gets pregnant at 30 years. So she has pre-existing diabetes or overt diabetes and now she's got pregnant. But there can be a girl who comes to me, she's got married at 25 years and she's never had diabetes in her life. And for the first time, her sugars start increasing after 24 weeks. She was never a case of diabetes ever in her life. But the sugars increase in the 24th week onwards. So that is known as gestational diabetes, gestation diabetes mellitus. So diabetes can also be like this, that she could be having a chronic or a overt diabetes and she's got pregnant. She's come to me at 7 weeks of pregnancy. She's already a case of diabetes. Or she gets diabetes for the first time after 24 weeks of gestation. You tell me which one will be worse. The diabetes which is present chronically, because if she is a diabetic chronically ever since she was 10 years of age, she'll be having nephropathy, retinopathy, neuropathies, all these problems will be there, or some damage to all these organs. If not frank retinopathy or neuropathy, some organs to this damage to these organs would have already started. So that's how we must understand that hypertension can present for the first time in pregnancy, diabetes can present for the first time in pregnancy. Hypertension presents at 20 weeks after gestation. Diabetes presents after 24 weeks after gestation. After 24 weeks, gestational diabetes. So we'll be talking about all of this. We'll be talking about gestational hypertension and chronic hypertension. We'll be talking about gestation diabetes and chronic diabetes. But you must have a basic understanding that chronic hypertension pregnancy and chronic diabetes in pregnancy will behave worse. That's the first part. But I want you to ask you a very simple question. If a woman gets hypertensive for the first time after 20 weeks in a pregnancy, if a woman gets diabetes for the first time after 24 weeks in pregnancy, what went wrong in the pregnancy? What was the reason because of which she has hypertension in pregnancy after 20 weeks and diabetes in pregnancy after 20 weeks? Yes, there's a common reason. Yes, it is the placenta which is the reason. Very, very important to understand. That's why it is called pregnancy-induced hypertension, gestational hypertension. Diabetes in pregnancy, which is gestation diabetes, is because of gestation. So what is the gestation doing to make this woman have hypertension and make this woman have diabetes? It is the placenta which is the main culprit. The placenta does not give good blood supply. Mother has to increase her blood pressure. Gestational hypertension after 20 weeks. Placenta is interfering with the endocrine and the metabolisms by making human placental lactogen in high amount after 24 weeks. That interference will increase the sugars in pregnancy after 24 weeks. So that's why in both the conditions, gestation hypertension, gestation diabetes, the placenta is the culprit. That's why we say moment the delivery happens, the woman becomes better with these two conditions. That is the confirmation of your diagnosis, that once the delivery happens, the blood pressure gets all right and the diabetes also gets all right. That's why it is known as gestation hypertension and gestation diabetes. All right. Keeping these figures in mind and keeping these ideas in mind, we'll get into the discussion. Excuse me. Let's move on and see. First, we'll see hypertension pregnancy, they'll get into diabetes. Yes, all of this probably you have read a lot of times and your teachers have also taught you, but let us just quickly do a revision today here. Gestation hypertension, blood pressure more than 140/90, protocol 5 sound we have to use. We have to use the muffling, okay? 140/90 after 20 weeks, 2 times, 6 hours apart, not one reading, and in a previously normotensive woman. Now, along with that, when there is proteinuria, we call it preeclampsia. But remember, this gestation hypertension is going to get better after the delivery. So that's why it is also known as the transient. It is also known as the transient hypertension. It is known as the transient hypertension. All right. Then what is preeclampsia? Along with this hypertension, there is proteinuria, which is more than 300 milligrams of protein in 24 hours or 1 plus or more on dipstick. The urine protein creatinine ratio, that means more protein is coming in the urine. So if this increases more than 0.3, that is also suggesting. So these are the methods of diagnosing preeclampsia. Just hypertension after 20 weeks, we say gestation hypertension. If there is proteinuria, we call it preeclampsia. And then along with that, if there are convulsions, tonic, tone, whole body tone increases first, whole body tone, and then clone, generalized tonic-clonic convulsions. Please, I'm not seeing any other type of convulsions. Tonic, clonic convulsions. All right. So that is what is known as eclampsia. Before I go into, I think I'm not able to see your questions. Just give me a moment. Yes, I think they'll fix it up. Let's get to work. So that is the basic 3 definitions: gestation hypertension, preeclampsia, and then eclampsia. Now, once a patient has eclampsia, this we say is the worst case scenario. Anytime a woman comes with high blood pressure in pregnancy, eclampsia na ho jaye. She gets preeclampsia. God, the stage before eclampsia is preeclampsia. This is also known as earlier as pregnancy-induced hypertension, also called preeclamptic toxemia earlier. So this is the stage before eclampsia. So you're worried, admit the patient and manage her because she's getting preeclampsia. And eclampsia means the worst case scenario. Why worst case scenario? Next, the patient is going to die. Yes. What happens next? She goes into HELP syndrome, hemolysis, elevated liver enzymes, low platelets. Then she has worsening of her kidney function. She'll have pulmonary edema, cortical venous thrombosis, and then she'll have DIC and she will die next. So that is the problem with eclampsia. Next, she's going to die. So guys, eclampsia means end of pregnancy. Yes, this is what they will ask you in your exams. When a woman has eclampsia, what do you do next? You will give magnesium sulfate, you know that. But what do you do with the pregnancy? The pregnancy is the cause of hypertension. Remember, the placenta is the culprit. So you have to remove the placenta, meaning you have to remove the pregnancy. That is the best management of eclampsia. So remember, we are doing the basic understanding of the topic, but the crux of the complete management should be understood right now. That if a woman has hypertension pregnancy, the worst case scenario is eclampsia, and she's had the eclampsia. That means take the baby out. The pregnancy does not continue after that. Magnesium sulfate and out. So that's why we teach you the way, we tell you all of this. Okay. So very important. There are some other definitions which you have to know. Chronic hypertension, that is pre-existing hypertension presenting in early pregnancy, which I told you just now in the beginning of the classification. This can be essential hypertension, renal artery stenosis, and pheochromocytoma. But there can be another third question which comes in your INICET many times. What is acute and chronic hypertension? There's a young girl who was having blood pressure ever since she was 15 years. She got pregnant at 30 years of age. And while she was Coming to me in the first trimester itself, she was a hypertensive. I started on labetalol or methyl dopa or hydrolysine, whatever drug. She's already a hypertensive in the first trimester. I've put her on some drug, whatever drug she was taking. Let's say she was taking a beta blocker or whatever she was taking. I have changed that and I've started a pregnancy safe drug in the first trimester. Now, while she was pregnant, at 20 weeks, she gets super added hypertension of pregnancy. She gets super added gestational hypertension. So that's why it is called acute on chronic. That means she was already a hypertensive. Now in pregnancy, she got acute on chronic hypertension. So that is super added gestational hypertension. So how do you diagnose that? The diagnosis of this is done by new onset proteinuria, first time protein coming in pregnancy, which was not there earlier. So that is the criteria of diagnosis of acute on chronic. Platelets become less than 100,000, that is less than 1 lakh. Creatinine 1.1 milligram per deciliter, and liver enzymes more than 2 times the normal. So that is the diagnosis of acute on chronic. There's another entity known as delta hypertension. Delta hypertension means her blood pressure was low throughout pregnancy, but later half of pregnancy, last trimester, it becomes a little higher than this. It is still in the normal range, but understand this delta hypertension. The blood pressure was normal throughout pregnancy. Later half of pregnancy, it is a high normal. Let's say in early pregnancy, the BP was 130 by 80. Later half, let's make it even more lesser. It'll be easier for you to understand. Early pregnancy, it was, let's say, 100 by 80. And later in pregnancy, it becomes 130 by 84. So this is normal and this is also normal. But later half of the pregnancy, it's become higher than the low normal it was. So it is high normal. You know what? If the blood pressure becomes 130 by 84 for a woman who was always 100 by 80, this itself can cause a woman to go into having proteinuria, and rarely patients have thrown convulsions, and you are surprised that the blood pressure is not so high. Why is she throwing a convulsion? So please understand, delta hypertension is also an entity, again an INICET favorite question. So we are still discussing the definitions. I told you about gestational hypertension, then I told you about chronic hypertension, and then I'm now telling you acute on chronic, and then delta hypertension. Let's move on and see the main question which is coming in all the exams, whether you're writing your final MBBS exam or you're writing your PG entrance exam. They're always asking you a stage which comes before the stage of eclampsia. The stage before eclampsia. It is not a defined stage, but it is a stage which is very important for you to know, because you can prevent eclampsia in that stage. So that is what is known as imminent eclampsia or impending eclampsia, or the stage of worsening hypertension. Wait, let me explain that to you once again in detail. There is gestational hypertension, blood pressure more than 140 by 90. Then there is proteinuria, means preeclampsia, and then she throws a convulsion, which is eclampsia. This one you understood very well. There is a stage which is here, it comes here. Before eclampsia, you can see some signs and symptoms which tell you that she's about to throw a convulsion. So you can prevent that convulsion from happening. What happens in a convulsion? She's convulsing, she's not breathing when she's convulsing, isn't it? Any woman or a man, any child who throws a convulsion, any moment of life, that moment the person is not breathing at all. So the person is not breathing, the person gets hypoxic. But what's worse, this woman is pregnant. The baby gets severe hypoxic brain damage, maybe born hypoxic and have brain damage for the rest of his life. Or maybe the baby will be dead intrauterine because of the hypoxia for 7-8 convulsions which this woman had. When a woman convulses, we know it can be bad for the mother, but worse for the baby. So if you can catch this before she convulses, that is what is imminent eclampsia. So how do you know she's about to throw convulsion? What are the signs of imminent eclampsia or impending eclampsia? Please mug up these signs: nausea, vomiting, headache, blurring of vision, epigastric pain, exaggerated knee jerk, reduced output, diastolic blood pressure more than 110, and proteinuria more than 2 grams in 24 hours. That is severe proteinuria. If it is more than 3.5 grams, we call it nephrotic range of proteinuria. So those are the problems which can be there when a woman is having this impending eclampsia. Catch the woman at this stage before she throws a convulsion and treat this patient. How do you treat this patient? Same management of eclampsia. What is the drug of choice for eclampsia? Magnesium sulfate. And then what do you do? Terminate the pregnancy. Then what is the management of imminent eclampsia? Give magnesium sulfate now and plan a delivery now, because you are smart enough to catch a woman at the stage of imminent eclampsia. Start giving Maxel, and also make sure you are planning the delivery, because she is now about to throw a convulsion. So that's what is imminent eclampsia. Extremely important for you to remember this. So what are the E2 pathogenesis? Now, basically, there are two stages of hypertension happening. One is the poor placentation, which I have already told you. I've given you a, I've leaked the answer before I started this topic. That what is the main culprit in gestation diabetes and gestation hypertension? It is the placenta. If the placenta is not formed properly, there will be increase in the blood pressure. Yes, I'll tell you that exactly how it happens. And then there is a maternal syndrome. So what is poor placentation, we'll see, and what is maternal syndrome, we'll see. There are two stages. We'll quickly go through this. You have read about this, but it's extremely important to revise. So in normal placenta, what happens? The blood flow from the uterine artery, and then the arcuate arteries, and then the basilar arteries, then the spiral arteries. They are giving blood supply into the placenta. How does the baby get the nourishment? Baby has got his villi. See this? These blue things which I have made. The baby is dipping the villi into the blood in the placenta. The baby doesn't take the blood of the mother. All of you know that. No blood transfusion happens across the mother and the baby. Mother could be A positive, baby could be, AB negative. So, mother could be O, baby could be B. So, all kind of blood groups can be there in mother and baby, but they can never be a mixing of the blood. So, how does the baby take nourishment? Baby will just dip his villi into the mother's blood. So, that villi which is going inside is dependent on a good placental flow. The spiral arteries which I have made here, these spiral arteries should give a good flow into the placenta, and that placenta which has a good amount of blood, the villi which has dipped into it are going to take the nourishment. So I'm going to show you this in a diagram here. Now look at this diagram, again inspired by Williams obstetrics. If you see, these are the spiral arteries, these are spiral arteries. See, same thing. These spiral arteries, I'm giving you a much better diagram here. So the spiral arteries are giving the blood into the placenta. So this black thing is basically the blood of the mother. And what is happening? The villi are dipped into this blood. So baby is not taking the blood of the mother. The villi are the suction tubes. These suction tubes are dipped into the blood, and the baby takes the oxygen, minerals, and the proteins and the carbohydrates and the lipids. Everything is sucked in, just like that. The mother is just giving the blood, and the baby is put his, these sucking tubes into this. That is what is known as a villi. So villi, if you look at this, my hand, and look at the villi, is just like this. It's a syncytium. It's a net. The villi is just dipped into the blood, and this the these fronds, these are called the the net which is dipped into the mother's blood. So this is known as the syncytiotropoblast, and this is lined by cells, cytotrophoblast. So they will go into the tissues. So the trophoblast which is outside the villi, they are trophoblast in the villi, cytotrophoblast. Then they are the trophoblast which is outside the villi. So we call him the extravillous trophoblast. See this term here, the extravillous trophoblast. They will come and they will replace this smooth muscle. Can you see the smooth muscle is slowly replaced by the trophoblast, and now there is no smooth muscle left. So as the pregnancy advances, see, early pregnancy, third trimester, there is a dilated blood vessel. There is no muscle. So that's why there is more blood into the placenta. Where there is more blood into the placenta, and that's what gives good perfusion in the placenta. This is what is normal. Now, if this is not proper, this is all the syncytoblast, and the cytoblast I told you is the villi, and then endovascular extravillous trophoblast. The trophoblast outside the villi will be replacing this. So that's what I taught you here. Now, if this is not happening properly, if this muscle, can you see this muscle here? If this muscle is not replaced properly and the old circulation persists, can you see the blood vessel is very narrow now? If you see this picture, the blood vessel in the early pregnancy is narrow. In the later pregnancy, dilated, more blood going to the placenta. But if it stays like this, the amount of blood going to the placenta is less. So the mother will increase her blood pressure to overcome this vasospasm. Mother will increase the contractility of her heart and increase the blood pressure, and that blood pressure will go through this and give nourishment to the baby. At the cost of increasing her blood pressure, mother gives nourishment to the baby. So yes, this vasospasm is the punchline of this chapter, hypertension pregnancy. I told you what is the cause of hypertension pregnancy? Poor placentation. If you know that, you've already passed your MBBS exam. But you want to get better marks in your MBBS exam, you have to say what is poor placentation. Poor placentation means vasospasm of the spiral arteries. Why vasospasm? Because the muscle is not replaced by the trophoblast. Getting complicated? You have to know this, guys. Do not get disinterested. If you're feeling that you did not understand, pause now, rewind and start again. I have not missed one line. So do not even think of dissociating from this topic. Hypertension pregnancy and diabetes in pregnancy, they are the only two cases which come regularly in your exam. Breech and coming in your clinical cases, long cases, unlikely. They'll ask you hypertension and diabetes. Basics. And in your PG entrance also, these two will always come. So don't get disconnected. Go back, rewind and listen and come back to this stage again. All right, guys. So we are talking about poor placentation, basically vasospasm. To increase this, increase the flow across this, the mother increases the blood pressure. So stage 1 is the poor placentation, which I told you what it basically means. Inadequate replacement of the muscle layer by the trophoblast. And persistence of primitive vasculature, persistence of the previous vasculature which was there in the spiral arteries before the placenta was formed. The same vasculature persists. So that's why there is vasospasm. And that vasospasm reason why the mother increases the blood pressure, more forcible increase to give nourishment to the baby. Now, when the blood pressure increases, it does not increase only in the placental area, isn't it? The blood pressure increases all over body. That same high blood pressure goes to the kidney, zigging. It just breaks the glomeruli and the patient will have proteinuria. It will go to the liver and the liver will have acinar damage and they'll be bleeding in the liver. Subcapsular hematoma. Remember I told you epigastric pain? Epigastric pain is not because of gas. It is because of a subcapsular hematoma. High blood pressure goes to the eye. Retinal, blurring of vision will happen because of papilledema. There can be retinal detachment. High blood pressure going to the brain, causing release of glutamic acid and causing the patient to have convulsions. All of that is based upon the high blood pressure which is going, and that high blood pressure is detrimental to all the organs, not just to the kidney, all over the body. So that is what is the poor placentation. So in addition to that, now quickly we'll go through this part. This is a little complicated. Keep your attention going for another 2 minutes and then it'll become easier for you guys. So in addition to the poor placentation, the vasospasm, what else is contributing to the vasospasm? We are still with the stage 1. We are talking about the poor placentation. What else contributes to the poor placentation? Maternal syndrome I have not started explaining so far. I am talking about poor placentation. So role of immune factors in poor placentation is, normally in all humans, the T helper 1 cells will mediate the secretion of the inflammatory cytokines, and T helper 2 is the humoral immunity. And in normal pregnancy, there is a T helper 2 cells bias. T helper 2 cells, these are the ones, the humoral immunity will be the major contribution of immunity in pregnancy. But what happens? There is a T helper 1 function increase in some patients, and this causes deficient vascular modification, and that results in vasospasm. How it results in vasospasm? Slightly complicated. We'll just leave that part. Just remember, T helper 2 function is more in pregnancy, but if T helper 1 function increases, it causes the deficient vascular formation. All those cytokines and those mediators of inflammation, they will increase and they will predispose to vasospasm. So T helper 1 function is what is going to increase, and that promotes to vasospasm. What else will promote to the contribution to all of this is the hypertension, is the maternal syndrome. Now we're getting into the second stage. I told you there are 2 stages of the hypertension pregnancy. One is the poor placentation and the second one is the maternal syndrome, that is the stage 2. So endothelial activation causes vasospasm. What is this now? Endothelial activation. Endothelium gets irritated, it gets in, the blood vessel goes into vasospasm. So basically what is happening? Poor placentation. What is poor placentation? Vasospasm. What is contributing to the vasospasm? Poor placentation, because of the muscles not getting replaced by trophoblast, and the T helper 1 function increasing. Now, there is something else, the endothelial activation causing vasospasm. So what is endothelial activation because of? The vasospasm can be contributed by the increasing in the vasopressors, angiotensin 2, thromboxane A2, endothelin 1. They will all increase, but there will be reduction in the vasodilators like prostacyclin. Prostacyclin is reduced, nitric acid is reduced. So all of these are reduced. So when this is reduced and this is increased, that will lead on to vasospasm again. So yes, there is a reduction in the ratios. That's what came in the INICET exam. So the prostacyclin and the thromboxane A2 ratio will be reduced, because if you say prostacyclin is here PGI2 and the thromboxane A2 is here, now this is constantly reducing and this is constantly increasing. So this ratio will reduce. So what happens to this prostacyclin thromboxane A2 ratio? That's what came in one of your exams, INICET exams. All right. So that's the reason for that. Now, in the etiopathogenesis, we are talking about the Maternal syndrome now, and Maternal syndrome, which is contributing to vasospasm, there is something else. Reduction in angiogenic factors and increase in the anti-angiogenic factors. This is what came in your INICET exam. So guys, don't even think of getting dissociated with the topic. Just keep holding the topic, guys. पकड़ के रखना है topic को, छोड़ने मत देना, निकलना नहीं चाहिए हाथ से. Come on, guys, push yourself. We are talking about placenta forming properly. So there should be blood vessel formation. For the blood vessel formation, there is help by growth factors. Growth factors makes angiogenesis. So growth factors are like the transforming growth factor TGF, vascular endothelial growth factors, also the placental growth factor PLGF. All of this will bind to the receptors on the blood vessels and cause angiogenesis. But when you have some inhibitors of these growth factors, those inhibitors like the soluble endoglin here, and the soluble FLT1, I'll tell you what is that. So soluble endoglin, soluble SFLT, they will inhibit. Soluble endoglin will inhibit the transforming growth factor to bind to the blood vessels. Soluble FLT1 will inhibit the vascular endothelial growth factors to bind with the blood vessels. So when this binding does not happen, the blood vessels do not dilate properly. So yes, endothelial dysfunction, impaired relaxation. When the angiogenesis is not proper, the blood vessels are narrow in diameter. So for the angiogenesis, you need what? Growth factors. What is inhibiting the growth factors? Soluble endoglin and soluble FLT1. So they will not allow the binding and there will be vasospasm, and that again is contributing to the poor placentation. So yes, please understand this. Same picture, the one picture which I showed you before, I am explaining that in a written manner here now. So angiogenic factors like the transforming growth factor, that transforming growth factor is reduced, and the vascular endothelial growth factor and the platelet, placental growth factor, all of these growth factors are reduced. How they reduced? The transforming growth factor is bound by the increase in the soluble endoglin. The vascular endothelial growth factor is bound by the soluble FLT1. What is FLT1? Soluble FMS like tyrosine kinase 1, SFLT1. Soluble FMS like tyrosine kinase 1. That will bind. Same what I showed in the picture, I'm telling you here. So these growth factors are inhibited by those anti-angiogenic factors, so blood vessels don't form. And that's what causes bad vessels, and that's what makes the mother increase the blood pressure. You're getting upset, I know. Too many words, too many names. Guys, you can just walk out of your rooms, go to the nearest path lab, and all you girls can go and get this test done. Even before you planning a family, you know. Yes, these values are high in early pregnancy for a lot of people. You can get this blood test done these days. This is commercially available, guys. Yes, commercially available test hai aaj ke liye. And you guys are thinking too much ho gaya. Please do not get dissociated. PIH is absolute must for you guys. Okay, remember we are talking about good formation of blood vessels, and if that is not forming because of anti-angiogenesis, that's what are the factors like soluble endoglin and soluble FLT1. Right. The other factors which are easy to remember are like This other factors I'm telling you, I'm just giving a summary, I forgot. So all these factors, poor placentation, endothelial activation and vasospasm, that's what causes bad blood vessel formation, and that's why the mother increases blood pressure to overcome the vasospasm. So I've told that many times, just that we are revising it here, right? So other etiologies which contribute: rest. Primary graders will have more chance of hypertension. Now we can do this part quickly. This is very easy to remember. And grand multigraders will have more problems. And also grand multigrader, you know, more than equal to 5 pregnancy grand multigrader. Twins and molar pregnancy, anemia, malnutrition will contribute. And also what is going to contribute? Genetic diseases like thrombophilia, the affinity to make thrombus. So blood vessels are blocked, mother increases blood pressure. And those thrombophilias are APLA and dysfunction of the MTHFR gene and the factor V latent deficiency. Please, with your medicine people, read thrombophilias, okay? Not the time to discuss thrombophilias in detail today. Pre-existing endothelial damage like in renal disease, diabetes mellitus and SLE. So diabetes is frequently correlated with hypertension. Yes, it happens many a times. And associated with IVF pregnancies, assisted reproductive technology pregnancies also will have more. So what is the pathology? The pathology is in the blood. First we'll see the hemolysis. Can you see these broken RBCs, the schistocytes? It is due to the microangiopathic hemolysis. Due to microangiopathic hemolysis, and that is going to cause anemia, increase in LDH because of hemolysis, and this hemoglobin which is free will be bound by the free hemoglobin is bound by the haptoglobin. So the haptoglobin is utilized to bind the free hemoglobin, so haptoglobin will be reduced. Schistocytes are these broken RBCs, they will increase. Then liver will have SNR damage. Liver will have SNR, the cell damage, and SNR damage will cause the increase in the enzymes. We call it the transaminitis, increase in SGPT, SGOT, okay, periportal hemorrhages, and that cause subcapsular hematoma. These subcapsular hematoma cause the epigastric pain, like I told you earlier. And then liver function, remember, is essentially normal. Liver is having a strain, liver is having increase in the enzymes, but it's doing its work properly. What happens sometimes that we get confused with acute fatty liver of pregnancy. Acute fatty liver of pregnancy is liver failure basically. There the things are totally damaged. Here the liver is having a hit, but it is still working normally. It is battered and bruised. It has got a hematoma also, bruised really, but it is still doing its work. So that's what is the basic thing you have to remember in hypertension pregnancy. Yes, eventually there can be a liver failure if you're not taking the means to correct it. There can be liver failure, but most of the time in hypertension pregnancy the liver is working normally with a strain on it. Right, central nervous system, microscopically there will be fibrinoid necrosis. There is fibrinoid necrosis and there is this perivascular microinfarcts. So because this perivascular microinfarcts and the fibrinoid necrosis, if these are seen in the frontal cortex, there will be headaches. If these are seen in the occipital cortex, there will be scotoma and there will be blindness. This changes if they are seen in these areas of the brain. They can be in many other areas causing respective symptoms, but mostly we talk about these. And then there will be cortical and subcortical petechiae, intracerebral hemorrhages, and then there will be release of neuroexcitatory neurotransmitter. What is this neuroexcitatory neurotransmitter? Glutamate, glutamic acid. This glutamate which is released is going to cause the convulsion. That's the reason. Right, what happens to kidney? Kidney will have something called the endotheliosis, capillary glomerular endotheliosis. So with hypertension pregnancy, there is reduction in the glomerular filtration rate and the renal blood flow. Why? Because of capillary glomerular endotheliosis. This word has come in your NEET exam already. Now let me try and explain this to you. What happens in this one? The high blood pressure causes endothelial damage. So this is a normal glomeruli. See, this is the normal glomeruli. Can you see glomeruli will get blood supply and the endothelium has these small fenestrations which give nourishment to the glomeruli. Now there is endothelial swelling. When there is endothelial swelling, this blood vessels get swollen up like this, blood vessels get swollen up. When the blood vessel gets swollen up, naturally these openings will get obstructed, they'll get closed. See, these openings are now getting closed. So these are the swollen fenestra, they will get closed. So when, can you see this picture? I'm sure you can understand. Look at this endothelial thickness here, look at the endothelium thickness here. It's a thick endothelium. When it gets swollen, these fenestrations will get blocked, and when they get blocked, there is poor perfusion to the kidney and kidney damage. So that's why acute renal injury, acute kidney injury we keep saying, isn't it? So that's what is the capillary glomerular endotheliosis. If you did not understand that, remember this name. This is what is coming in exams, capillary glomerular endotheliosis. I am sure you understood this also. If you did not, then go ahead and replay this, guys. Fine. So there is this damage is due to increase in the renal afferent arteriolar resistance, and this will block the filtration. Capillary glomerular endotheliosis blocks the filtration and cause the renal damage. Then of course there will be the HELP syndrome, which you know is because of the the ongoing damage to the body. There will be hemolysis, elevated liver enzymes and low platelets. Hemolysis diagnosed by the Burr cells, schistocytes, bilirubin more than 1.2 milligrams per deciliter, low haptoglobin, which I explained to you. LDH is 2 times what is the normal value, it is twice that, so more than 600 units per liter. And then elevated liver enzymes, which I told you, more than twice the normal, low platelets. Now impact on the eyes, there can be retinopathy, and that retinopathy is seen in almost 100 patients. Matlab, can be various degrees. It does not have to be bad retinopathy with blurring and papilledema and detachment always. Mild, moderate, severe type of retinopathy is there. I'm sure the opthal teachers are going to tell you the retinopathy stages and all that also. But remember, retinopathy is seen in almost 100% patients with eclampsia. 100% patients of eclampsia will have some retinal changes, but in 30 to 40% patients of pre-eclampsia also will get the retinopathy. Symptoms can be blurring, photopsia, scotomas, and there will be arterial narrowing, retinal hemorrhages, cotton wool spots, macular edema, and even papilledema. Right. So yes, I took a lot of time to explain you the etiology and pathology, but all of this is the impact, and let's get into the treatment. The treatment part is more important. Okay, retinal detachment also there, fine. Treatment of hypertension pregnancy. Look, OPD management, you know the drugs. The drug of choice is labetalol, and I'm just going to tell you the name of the drugs. Okay, please remember the pharmacology you read. We are trying to do a quick revision. Read the pharmacology, I'll just tell you the name of the drugs, but remember, gestational hypertension can be managed at home. Yes, just high blood pressure can be managed at home, but if there is proteinuria and the patient is having pre-eclampsia, then we tend to admit the patients. All right, so this can be managed at home. Antihypertensives can be given, but pre-eclampsia always admit. Evaluate the peripheral smear, the clotting profile, liver enzymes, give steroids, because in hypertension complicating with proteinuria, you may think in terms of doing an early delivery, so you may have to give steroids to get the lung mature. For the early maturity of the lung, we may have to deliver the baby by, let's say, 34-35 weeks, so maybe even earlier because of hypertension, and she's going into preeclampsia. If you're having that, then you may have to give steroids for lung maturity. So maternal surveillance, 4-hourly blood pressure, and the weight gain you have to see not more than 500 grams of weight gain in a week. Okay, urine routine, uric acid, creatinine, LFT, LDH, all of that will help you diagnose the organ damage. And then very, very important, fetal surveillance. That is what is the most important topic of obstetrics, fetal surveillance. Any woman having pregnancy, we are very vigilant about pregnancy. So all women are seen in the antenatal OPDs. But when there are high risks, we increase our surveillance. So surveillance is what is obstetrics. Before we get into diabetes chapter, understand whether it is hypertension pregnancy, diabetes, twins, intrauterine growth restriction, heart diseases, any problem in obstetrics, we increase our surveillance. Surveillance, look, what is the drug of choice for hypertension pregnancy? Even before the lecture, you know it is labetalol. What is the drug of choice for diabetes in pregnancy? Insulin. That also you already know. Does that make you an obstetrician? No. You became an obstetrician only if you know surveillance. Because knowing the hypertension and knowing that you have to admit her and knowing that the kidney is getting damaged, you have to continue the pregnancy as far as possible. You have to take care of the mother. You have to take care of the baby also. So for the baby, you have to be very vigilant. So both mother and baby should be good and continue the pregnancy till as close as possible to term. And for that, you need your surveillance. And to do surveillance is what is obstetrics. You admit her, you check the movements of the baby, check whether the baby is having a reactive NST, and you check if the baby is having a good amount of liquor around him, and you check the movements, which is known as the biophysical profile. You see the blood flow to the baby, Doppler, and you buy 1 week. Then again, you do all these tests, buy another 1 week. Slowly, you're taking the pregnancy towards term. Surveillance is the only topic in obstetrics without which you cannot attempt any exam, be it your MBBS exam or your PG entrance or MCI exam, whichever one you're writing. Do not go out without surveillance. We are discussing surveillance in a few days from now. But remember, in every high risk, the surveillance increases. So I'm just saying, see the mother, do these investigations, see the baby also. We'll discuss the details in a different day. So far, we're talking about the treatment of hypertension. So let us see the drugs. We are talking about the hypertension management, OPD. OPD management, this is alpha plus beta blocker, and we avoid it in asthmatics because it's a non-selective beta blocker. But I'm telling you only this much. I'm not going to detail of pharmacology today. The other drug we can give is hydralazine. It's an arteriolar dilator, and that is going to reduce the afterload on the heart. It's a good drug, one of my favorite drugs. But yes, previously the drug of choice was methyl-dopa. Methyl-dopa is a prodrug. It gets converted into alpha-methyl norepinephrine. We give it 250 milligrams to 500 milligrams 4 times a day. It causes side effects of drowsiness, depression, and also a false positive indirect Coombs test. Again, we'll just move on. There are drugs, more drugs like nifedipine, prazosin, all those drugs are there. So we are just talking about the management of eclampsia, which is more important, those details. Rest you read the pharmacology. Now, what are the contraindicated drugs? Now, this is, you have to know this properly. Favorite exam question. Favorite means all, there are 5 entrance exams in a year. 2 of INICET, 1 of NEET, and 2 of MCI. And this will come in at least 3 exams, maybe sometimes in 4 exams. Contraindicated drugs in hypertension pregnancy. So furosemide should not be given. It causes intrauterine growth restriction. Furosemide reduces the circulatory volume of the woman. So what is the problem? Blood pressure will reduce, right? What is the etiology of hypertension, guys? Etiology of hypertension is what? I told you one punchline, poor placentation. Then I told you what is the meaning of poor placentation? Vasospasm. And when there is vasospasm, there is more perfusion or less perfusion? Less perfusion. So when there is less perfusion to the fetus, because of that, the mother is increasing the blood pressure and giving some nourishment to the baby. Now at that time, we must understand the circulatory volume of the mother is important to give some nourishment to the baby. So we need the circulating volume. The mother is not having hypervolemia. Please, once again, you and me, if we get hypertension, non-pregnant women, men, whenever we get hypertension, we are mostly having volume overload. So that's why furosemide can be given. But pregnant mothers have a problem of poor perfusion to the baby. And then you give her a diuretic, there will be still lesser volume in the mother and lesser perfusion to the baby. The baby will get intrauterine growth restriction. That's why hypertension etiology is totally different from hypertension pregnancy etiology is totally different from hypertension to normal humans. Yes, there is no volume overload in pregnancy induced hypertension. There is no volume overload. There is actually poor perfusion. You cannot take out more fluid from the mother. So that's why furosemide is contraindicated. I'm not going to write all of that, guys. Okay, so remember furosemide, IUGR, because this much you must remember, because pathology is vasospasm. Remember that. Then beta blockers, again, beta blockers if you give, they're going to cause intrauterine growth restriction. But what is the drug which they'll keep asking you many times, which is contraindicated? AAC inhibitors, because AAC inhibitors, enalapril, captopril, lisinopril, some example they'll give you. They're going to cause hypocalvaria, reninoligenesis, oligoamnios, and limb contractures. So that's why AAC inhibitors are contraindicated in hypertension pregnancy. Now, hot shot part of the class is the treatment of eclampsia. Resuscitate, maintain airway, prevent injuries, any convulsion, you'll do that. But what is the management of the medical management of this convulsion? That is what is coming. Any convulsion, you have to manage the way general management we've told you. But what is the management of the eclampsia? So, drug of choice is magnesium sulfate, and the regime of choice is the Pritchard regime. It is the Pritchard regime, okay, and that is given IV plus IM. Okay, so Pritchard regime, which is given IV plus IM, is that drug which we have to give. So the dose given is IV, we give 4 grams, and the IM dose is 10 grams. Mind you, the dose is in grams, not in milligrams. So 14 grams is the loading dose. Also, we can give 2 grams more, 2 grams extra if it is required. If the convulsion is not stopping, we can give 2 grams extra IV. 2 grams IV we can give extra. So yes, 4 grams is given IV, 10 grams is given IM. IM is split into both the buttocks, right and left. We give 5 grams in one buttock and 5 gram in the other buttock. And because each is actually in 10 ml, it is in 10 ml. That's why it's a big volume injection. That's why you have to split it. Sometimes we even add lignocaine to prevent the pain in the muscle because of such high volume injection which you are giving. So the level of max which is achieved is 4 to 7 milliequivalents per liter. That's the level we want to achieve when we're giving magnesium sulfate. So yes, next, what do you do? When the woman is having hypertension pregnancy, you're worried that she should not have preeclampsia. When she's having preeclampsia, we are worried that she should not have eclampsia. Now, when eclampsia happens, what is next? She's going to die. Remember, that's how the chain of events I told you. So, eclampsia is the time now nothing will continue. The delivery has to stop. So, you give the magnesium sulfate, but start the delivery process. You have to do that. You have to start the delivery process. Next, do the delivery. And that reduces the blood pressure to normal in 90% of patients in 1 week. That's why we call it the most definitive management. Yes, it is called the most definitive management of eclampsia. Very important MCQ here. Okay. The blood pressure is normal in 90% patients in 1 week. So continue MaxHealth after that. Suppose she delivers at, let's say, 7 p.m. she delivers after the convulsion. We have done a cesarean or we've done a normal delivery. Look, I did not say that cesarean is a method of delivery. No, 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 no. Don't get me wrong. If a mother is in labor, let's say she is 38 weeks and she's in labor, and during labor she throws a convulsion, you know she's going to deliver. She's 4-5 centimeters, she's going to deliver. So you control the convulsion and make her deliver normally. Another 3-4 hours she'll deliver, and you control the convulsion. But suppose she throws a convulsion at 35 weeks and the cervix is tight, os closed, bishop is like 2 or 3, unfavorable bishops less than 6. So if it is unfavorable bishops, even if you induce labor, she's going to deliver probably tomorrow or day after tomorrow. Then you can do a cesarean. So the mode of delivery is not important. What is important, you must understand that you have to deliver whichever method is appropriate that time. Now continue magnesium sulfate 5 grams 4 hourly for 24 hours. 5 grams 4 hourly for 24 hours. And remember, this is where you have to take care. When you're giving this, how do you manage? How do you monitor this? So monitoring the magnesium sulfate is coming, because magnesium sulfate is a cerebral suppressant. It is going to suppress the brain. If it is suppress the brain, it is suppressing the brain to stop the convulsion. But the suppression can be so bad that she can even have a respiratory depression. So you must monitor 3 things. In addition to blood pressure, pulse rate, all that, you have to monitor 3 very important things. Knee jerk should be present, and the respirator should be more than 14 per minute, and because magnesium sulfate is a cerebral suppressant, that's why these two should be at these values at least, and urine output should be more than 100 ml every 4 hours. Why I'm saying every 4 hours? Because you have to give 5 grams 4 hourly. So when you're giving magnesium sulfate, it is stopping the convulsion. But if the max self is too much, you'll have respiratory arrest. So make sure the max self is getting washed out also from the body, and magnesium sulfate has renal excretion. The urine output should be more than 100 ml in the last 4 hours. So suppose I have seen the delivery of the woman happens at 7 p.m. Then 11 p.m. you have to give the next dose. 3 a.m. you have to give the next dose, 7 a.m. the next dose, 11 a.m. tomorrow. So when I'm going to give the dose, let's say at 11 a.m. tomorrow morning, at that time the renal output for this last 4 hours was only 70 ml. That means the magnesium sulfate is not going out of the body. This is what they'll ask you in your exams. Final year MBBS, this is the time when you should remember. We are doing detailed, even though I was told that I must just do a revision. Till your MCA exam, I'm making sure that you guys have lot of detailed discussions on the major topics, in addition to my final years getting an revision for their exams. So yes, you have to understand that urine output should be more than 100 ml in the last 4 hours, and they'll ask you that if it is less than 100 ml, then what do you do? Suppose tomorrow morning 11 o'clock I'm going to give the next injection. I have to give it for 24 hours after the delivery. 11 o'clock when I see the output is less than 100. If the output is less than 100, what happens? That means the clearance is not good. So withhold the next dose. I'm not going to stop the max self totally. I'm going to withhold the 11 o'clock dose. I'm going to see her again at 3 p.m. At 3 p.m. if the parameters are fine, I give the next dose. So for 24 hours after the delivery, we have to give the magnesium sulfate. All right. So yes, that is what is extremely important. Before I tell you about I'll see the questions. Wait, just I'll tell you more of this. If any of these are not met, then you have to withhold. That I told you already. Then magnesium sulfate toxicity. I'll just deal with this, and then I'll see the app for the questions which you people are asking me. Okay, I'll see your questions. Yeah, I'm on again, guys. I'm so sorry for the delay. All right, so we are talking about the magnesium sulfate toxicity, and we're talking about the magnesium sulfate toxicity. We are discussing that if the magnesium sulfate is too much, then we have to stop the next dose. We have to withhold the next dose. So how do I know? How do I know that the magnesium sulfate is getting into excess dose? So first sign of toxicity is at 8 to 10 milliequivalents, because normal what you require is 4 to 7 milliequivalents. So more 8 to 10 is going to cause knee-jerk suppression. It's going to cause a knee-jerk suppression, and 10 to 15 is going to cause a respiratory depression, and more than 15, see, more than 15 is going to cause a respiratory arrest, and if it is more than 25, it's going to cause a cardiac arrest. So that's the problem with magnesium sulfate. So if there is too much of magnesium sulfate circulating in the body, that is going to cause the patient to have the problems of even a respiratory arrest and cardiac arrest. So treatment is calcium gluconate. All of you know the dose, 1 gram intravenous over 10 minutes, and you give it in 10 ml solution. So this keeps coming in your exams. How much is the dose of calcium gluconate? So now maybe I'll see your questions. What is fenestration? Fenestration means a small hole in the blood vessels, small hole through which the nourishment is going. Fetal surveillance we are not going to discuss today. It's a long topic. We have a dedicated topic discussion of fetal surveillance, my friend. Fetal surveillance, I've told you the tests like NST, biophysical profile, Doppler, and all of these are the tests, but we'll get to that in a proper discussion later. All right. So blood pressure control in the stage of eclampsia. Look, what we discuss in the outpatient department, that is hypertension is there, we give tablet labetalol, tablet methyl-dopa. Now we're talking about a woman who is convulsing. So how do you control the blood pressure in a woman who is convulsing? You cannot give oral drugs. She may aspirate if she convulses again. So we have to give IV labetalol. So IV labetalol is given 20 milligrams, and we can keep doubling it every 20 minutes if we don't get a control, that is. So 20 milligrams IV we give, and then after 20 minutes we can give another 20, or we can make it 40, or we can make it 80. So total in 24 hours we can give up to 220 milligrams in 24 hours, as much as this much, 220 milligrams, to get a control of the blood pressure. So we can predict hypertension by the rollover test. from the supine position to the when the mother is lying down supine, and if you make her I'm so sorry, if the mother is lying down lateral position like this and you make her supine, so the weight of baby will press over the vena cava and the venous return will reduce, so the output will reduce. So what happens, the mother increases, a reactionary increase in the blood pressure is done. So that blood pressure increases only by 10 millimeters of mercury. So if that rollover increase the blood pressure more than 20, if the rise I'm sorry, if the rise is more than 20 millimeters of mercury, that is a positive reduction, that around 20 to 32 weeks, if the blood pressure rise from the lateral to supine, from lateral to supine, if that is what is increasing the blood pressure more than 20 millimeters, that is going to predict that she's going to have hypertension. Isometric exercises, that is sustained hand grip, if that increase the blood pressure more than 15 millimeters of mercury, and then increase uric acid levels, all of this will predispose. Uric acid generally more than 6.5 is going to predispose that the woman is likely, more than anytime more than 5 is detrimental, more than 6.5 we are already thinking in terms of the woman that we have to terminate the pregnancy. So high uric acid levels, isometric exercises, rollover tests. And then how can you prevent? You can prevent having hypertension pregnancy by giving low dose aspirin, which is 75 milligrams or 150 milligrams, because the full dose is 300 milligrams of aspirin. We're giving low dose 75 or 150 milligrams. So that is one mechanism, and it reduces the platelet thromboxane production. That's why it is good. Platelet thromboxane production is reduced, and that's why thromboxane increase is going to cause vasospasm. So you can reduce that. Calcium supplementation reduces the membrane irritability. So calcium supplementation pregnancy is good. Then omega-3 fatty acids, fish oil has it. So this omega-3 fish oil, this is going to, the omega-3 fatty acids, this is going to replace the arachidonic acid in the formation of the steroids. So the arachidonic acids, if it is replaced by this, then the formation of prostaglandins is reduced, and that's why the vasospasm will be reduced. So arachidonic acid is replaced by the omega-3 fatty acids. This fish oil, it is having a lot of omega-3 fatty acids. That's why Japanese people, who are mostly having fish-based diet, they have the least incidence of hypertension pregnancy in the world because of their diet. A lot of other fish eating countries are there, but they eat all the other kind of food also, which is high in fat and all. But Japanese people have far more disciplined lives, and they are totally into fish. That's why they have the least incidence, because of this high amount of fish oil. And that is what is the omega-3 fatty acid is going to replace the arachidonic acid.